Hello everyone, I'm Taha Mohammed. I'm a fourth year medical student, and in this video, we're going to continue our asthma series by looking at the clinical presentation of asthma. So we'll have a look at the different clinical signs and the typical presentation of what asthma actually looks like within patients, and we'll also jump into a little bit of why those symptoms are actually occurring. So let's jump straight in. So welcome our patient back, Mr. Whitecoat, right? And we'll go through just some of the classic presentations of what asthma and how it presents. So we understand the physiology of asthma is that it is a chronic condition, right? Now, even though it is a chronic condition, this doesn't mean that the patient will always experience the symptoms that we're going to talk about. So it's not a perpetual thing. It's defined as a chronic condition that's exacerbated acutely, and we'll have a look at what causes those sort of exacerbations. So we will look at the first symptom is the classical wheezing, right? The second one we'll look at is cough, and the very last symptom we'll look at is dyspnea, right? So let's have a look at the wheezing aspect, okay? So the wheeze in asthma is actually what we call a polyphonic wheeze, right? I'll explain what this actually means. To understand what polyphonic and monophonic wheeze actually is, we'll look at the pathophysiology of why the wheezing actually occurs, right? So within Mr. Whitecoat's lungs, the wheeze occurs by a constriction of the airways, right? So if you imagine within a normal patent airway, right? So this is a normal airway. Air will pass through this airway, right? And it'll go out without making any sort of, turbulent sounds or high-pitched whining or any sort of pitch, really. Now, in asthma, as we know, there is inflammation. And as we know in inflammation, when inflammation actually occurs, we also get smooth muscle constriction. Now, when the smooth muscles actually constrict in asthma, it means that there is a more narrow passage for the air to actually travel through, right? And when this passage in the airways is actually narrowed, it means that the pitch will increase, right? So the wheeze that we hear in asthma is actually just wind or air, breath, breathing, passing through the constricted airways. You can try this at home actually. If you take your mouth and blow air out through a normal patent airway, so just blow air out. Now, if you purse your lips together and blow the same amount of air out, there'll be a whistling sound, and that's obviously caused by the decrease in the area. So that is what the wheezing is actually caused by. Now, if we go back to what the polyphonic and the monophonic means, it's polyphonic just means that the airways within the lungs, right? So all of the airways within the lower respiratory tract, so the bronchi, they all constrict to varying degrees, okay? So some airways may constrict this much, some may constrict this much, some may constrict just a little. And now the variation between how much they're actually constricting will contribute to different level of the pitches, right? So the more narrow it is, means that the higher the pitch. Now, when you have all these different types of pitches, if you take a stethoscope and put it onto the patient's lungs, you'll hear a mixed picture. So there will be different tones, and the pitch will be different in the actual airway. Now, compare that to a monophonic wheeze, right? A monophonic wheeze is not characteristic of asthma. So if we have a look at the airway again, This monophonic wheeze usually, it means either there's a foreign body within the airway, so it could be a child who may have swallowed a bit of Lego. It's a terrible representation of a Lego, but you get the point. So again, same sort of idea. So when there is that sort of narrowing of the airway, it means that the air pushing past will make a pitch, right, a higher pitch sound. Now, important point to mention here is that the monophonic wheeze will only be specific to one area, right, not widespread like it is in asthma. Another thing it may be caused by is something a little more sinister, such as a tumor, right? So a lung cancer that might be growing, and that can also cause a monophonic wheezing. Okay. Now, now let's have a look at the coughing. Okay. So what is the coughing actually caused by? So we understand that it is usually chemical irritants or certain particles that go into the patient's lung, and because their lungs are hypersensitive, they have an overreaction to these irritants. Now, when the lungs are irritated by these particles, like we mentioned, they constrict, right? And this constriction can activate the cough receptors, right? It can be the constriction or the actual physical, chemical irritants themselves that can activate these cough receptors, which will trigger the cough reflex, right? And the reflex is realistically is there to help us, prevent inhaling particles that shouldn't be there in the first place. So it's trying to expel the particles and the irritants that are within the lungs. So that is one reason why cough actually occurs with patients in asthma. Another reason is because of the mechanoreceptors, right? So within the airways, there are also mechanoreceptors that respond to the constriction, right? When the smooth muscles actually constrict, mechanoreceptor responds to that and can also trigger coughing within the patient, right? Now the final thing that we'll look at is dyspnea, okay? Now dyspnea just means, it's a fancy way of saying shortness of breath, or just simply SOB, okay? Now, why is dyspnea actually occurring within patients with asthma? The main reason why is because there is a decrease, right, in the patency of the airways, like we've mentioned. Now, if you imagine taking a straw, right, and putting it in your mouth and trying to breathe through that straw. Now, if you're at rest, this might be fairly straightforward and it may be simple. But if you imagine patients who have had increased workload, right, of the lungs, so maybe they're exercising, or maybe they need, more oxygen delivery to the body, then when the respiratory rate increases, it means that there is a severe, lack of air actually entering the lungs. So if you can try this at home again, if you take a straw and do 20 jumping jacks, you can start to see how difficult it is for patients to breathe through these narrow airways, right? Um, so that's one way that the dyspnea actually occurs. So the second thing we can actually look at is something called dynamic hyperinflation, right? Now, what does that actually mean? So, dynamic hyperinflation means that, so we understand that the pathophysiology of asthma is that it's an obstructive condition, right? It's an obstructive pathology. So it means that air cannot exit the lungs, right, as it should. So what this means is that when a patient exhales, right, there is going to be residual air, so residual volume of air left within the lungs. So it's going to be trapped within the alveoli of the patient. Now, when that happens, the patient is going to inhale again, right? And that cycle, it repeats. So if you inhale, but you haven't expelled all the air, it means that over time, that there is going to be an increase in the residual volume of air that's actually trapped within the lungs. Now, when this happens, it means that it increases the pressure, right, within the lungs, right, because there's an increase in the residual air volume. Now, when there's an increase in pressure, it also means that it's even more difficult to get air, into the lungs, and that also contributes to the SOB that we see in patients with asthma. So, so now we've had a look at the three main sort of symptoms, so the wheeze, cough, and then the SOB, right? And we've also mentioned that patients with asthma don't, chronically have these conditions or these symptoms. They only come on when there is an acute exacerbation. So when during those times, when would they actually occur? So the times where patients may experience those symptoms is when there is a stimuli or irritant. So this could be things such as, dust particles. It could be smoking, could be damp, like dirty air, so sort of dirt. Some people are quite allergic to animals as well. It could be things such as exercise, because there's increased demand for oxygen during this time as well, and also things such as, cold weather. And one other important point to mention here actually is that asthma is typically worse at night, okay? So let's understand why asthma is actually worse during the night for some patients. So we understand that cortisol, right, which is our body's natural sort of steroid hormone, it keeps inflammation down within our body. It actually is the lowest, it drops as we go to sleep and spikes in the morning, right? So as cortisol drops throughout the night, it means that inflammation has more of a chance to cause symptoms within patients, right? Another reason is because the airways are naturally more narrow during the night, okay? Now, this is completely normal and it happens to everyone, but obviously because patients with asthma are more susceptible, so it typically presents worse with patients who have asthma. Another reason is because obviously you're lying flat, right, within the body, so during the night, sorry, and this means that more blood can actually perfuse the lungs, right? And this means that it can cause it to be a little bit more congested, which can also lead to some of the symptoms that we see, especially the dyspnea and the shortness of breath, typically worse throughout the night. All right, thank you everyone for tuning into this video. This was the clinical presentation of asthma. In the next video, we'll have a look at some of the investigations that we can do, and we'll also have a look at the management options that are available with patients with asthma. Thank you all for watching.